Welcome to the June edition of Peer-to-Peer Academy. I'm joined by my awesome friends, my close partner in crime, Dr. John Vukich, at Summit Eye Care in Milwaukee. A good buddy of mine, Jeff Banas, and then his partner as well, Dr. Paul Singh, down at the Eye Centers of Racine and Kenosha. Thanks for joining us, guys. Appreciate it.
Thanks
Thanks
for
for having
having
me.
us.
Yeah,
Yeah,
glad to be
excited
here.
to be here, Nick.
So tonight's theme is all about collaboration. You know, the light adjustable lens and the way I think optometry and ophthalmology are going. I mean, we're really kind of trending towards this collaborative model. Collaborative care is kind of a buzzword. And I think the light adjustable lens truly exemplifies what collaborative care actually means. And so what we want to talk about tonight is how we embrace collaborative care, how we use the collaboration between OD, MD, the entire staff, and our referring network, how we collaborate as a true team to optimize outcomes. So let's get started. Paul, I want to talk to you first. I want to ask you, specifically because your practice is large. I know you guys do a lot of high volume, pretty cool stuff. When you brought in the light adjustable lens, how did that go? Tell me the process about how you brought it in.
Yeah, I mean, it was actually about a year or so of thinking about it and saying, is this worth it? Is it not? Is it worth it? Is it not? Type of thing. But when we finally brought it in, I'll tell you personally, I thought it was going to cannibalize a lot of my premium IOL market share in terms of, take away my multifocals, take away some torics, take away X, Y, and Z. But what I started to realize really early on when we started to bring it in, and one of the reasons why I brought it in was because it actually opened up a whole new category of premium options for patients where that they would have not had a premium option. Patients who, let's say, weren't great candidates for multifocals or really just cared about quality of vision more or less, or just nailing their distance vision. And so for me, it was about quality of vision and really saying, how can I maximize the eye's ability to see the best it can, depending on whatever pathology it had, right? So as a glaucoma specialist or someone to see a lot of dry eye, et cetera. And that was the mentality of why I really thought bringing in something like a light adjustable lens was so important for me, is because I thought it was going to bring, this kind of quality of vision worlds that I didn't have with all the other lenses to that state. And so that's what happened actually when we brought it in. It did not cannibalize. It actually grew the market for us and grew a whole new population of patients where our focus is really on quality of vision, maximizing the potential for that eye. And so that was really the exciting part of it. But when we brought it in, it was me doing a lot of the things myself. And so I brought it in, and my partner, Krishna Sanka, as well. And so we did the surgeries. We did all the adjustments and the lock-ins ourselves. And I'm sure Jeff will talk to you about that, but it was very time consuming to do all of that ourselves. Now we relied on our optometry colleagues, Jeff and Jess Schiffbauer and other people in the practice. But we did the adjustments physically ourselves, and we rely on them for the refractions and some of the feedback. But we very, very, very quickly realized that yes, I wanted some good understanding, good experience with the adjustments and the lock-ins to understand how that whole process worked, how to use the LDD, the machine. But we realized we needed to work more closely with our optometric colleagues in-house, which is Jeff and our other colleagues, to not only get a better efficiency and flow of a plan, but really also the procedure itself. And so to do the adjustments and the lock-in. So very quickly we transitioned to having Jeff and the optometric colleagues in our practice do the adjustments and the lock-ins. And I'll let Jeff talk to you about that. But to me, what it did was it really allowed me to have much more of a collaborative atmosphere and a collaborative work relationship with Jeff. Because now it wasn't just me telling him what to do. He was telling me, like, hey, this is what I'm doing for your patient. And it became less about me as a surgeon and the optometric colleague as just being the person who was just following that patient and having really nothing else to do, where we are both equally involved and equally important in the journey of this patient. And so when Jeff would send me a patient to cataract surgery, Jeff has taken that patient back, and Jeff is as involved in this person's outcome as I am as a surgeon. And I thought that was probably the most exciting part of it. And that's kind of how we transitioned from really start to now where we're at with the LAL.
What about you, John? I mean, I kind of know your story because I've been a part of it, but why don't you talk about how, I think, Paul, what you mentioned, you got your hands on it first. And that's important, I think, for anybody to really understand the technology. So you really understand the nuance. It's a fantastic technology, but it's not exactly plug and play. You do have to learn, and there is some bumps along the way. John, why don't you talk about our story when we started this 5 years ago?
So my path was maybe slightly different, Paul, in as much as I started a new practice. I left my previous practice and started up a private practice, which has, quite frankly, been just about the best move I've ever made. It's worked out wonderfully, and having Nick as a partner has been, absolutely great. And we decided to build, or I decided to build our practice around technology, as I've always been a part of. And the light adjustable lens, it's like the world's longest overnight sensation. It's been in development for well over a decade, and with various iterations. And it was about 5 years ago when it started to make sense. They had been able to do some modifications to the implant itself to make the lock-ins a little bit better and to make the UV blocking a little bit better. And quite frankly, it reached a point where it just made sense, and the results were undeniably amazing, and quite frankly, better than anything that I had seen with just standard IOLs. What I didn't really appreciate at first was the ability to achieve good near vision with the lens without necessarily sacrificing the distance. So we talk about, a blend of vision that gives a really high quality distance as well as near, and you can titrate it. You don't have to assume what the patient likes and then they just get what they get. They have the ability to let them try it out. So from my perspective, it was a low risk alternative that provided a new level of care for patients to be involved in their outcome. And so from that standpoint, it became really a growth factor for our practice. Word of mouth became, one of our biggest referral bases. Patients who, we started taking care of some pilots, and the next thing you know, they start showing up and they really want tack sharp distance vision so they can land their planes at night with their families on board and not worry about depth perception, not worry about being able to spot another aircraft under visual flight rules at a distance with high closure speeds. I mean, all the things that we all understand as we want to see well, but some people are just absolutely, their life depends on it in some regards. So we started with that. And Paul, similar to what you described is, it's a journey, right? And so having the conversations with the patient to decide, where are you going to go? How does this, going to affect your life? And then achieving that goal with incremental discussions along the way. We do the first adjustment and say, all right, how are you doing? What can we make better? What is it that's, driving your level of satisfaction? And can we do something more? And it became very clear to me that, it is not only time consuming, but quite frankly, Nick has been just a true partner and colleague. I don't do 25 refractions a day. And I'd like to think I'm pretty good at it, but it would be hubris for me to say that I'm as good or better than Nick at doing refractions and getting a solid endpoint in order to drive the next level of treatment. So it became such a clear collaborative effort that, all right, I'll get the implant in, we'll start the initial conversation, but how do we end up where the patient wants to be? And that's where, Nick has just shined. And quite frankly, it has been, I say, a team effort that really works so well. I mean, I quite frankly, I couldn't imagine not having that level of support and that level of opportunity to make the patient's journey both smooth and get the best result.
Yeah, I like to introduce myself before surgery as much as often as possible, at least to put a face to the voice, because I know Dr. Vukich, when you see these patients for their evaluation, their pre-op, you kind of introduce the idea and you say that my colleague here is going to take over for the an important part of your process here. And I think for patients, sometimes when we started doing this, that was a little bit daunting. The stranger's going to come in a very vital, important piece of this journey and take over. That seems weird. So I like to introduce myself beforehand and just say, hey, I'm, Dr. Bruns. Nice to meet you. Let's talk about how we're going to really make your vision awesome. Jeff, how do you do it? When do you introduce yourself? Or Paul, maybe you introduce Jeff. How does that work? How's that dynamic work in the patient's journey?
I think it's really a combination of both. Fortunately for us, we're a comprehensive ophthalmology practice. So a lot of times I'm seeing these patients for, other things. You name it. We're talking like complete exams, dry eye checks, pressure checks, things like that. And then, over the journey that I might have built in just patient care with this patient over a number of years, I've sat there and I've gone, now your cataracts are visually significant. It's not so much Paul handing off to me, but me handing off to Paul and going, I'm going to have you see, my colleague and an excellent surgeon, Dr. Paul Singh here, and he's going to take a look at your cataracts and recommend, really what the best option for you he feels is. But let me tell you about some great options that I think you might want to inquire about with him. And I'll talk LAL, predominantly because I feel like it's the best thing that I can have to give the patient, a lot of times that range of vision that they're looking for so that they kind of have an idea of what's coming and what might be discussed in that conversation. Now, ultimately, that's up to Paul to decide what's most appropriate for the patient from a surgery standpoint, or at least that's how we do it in our practice. But a lot of times I've already been introduced to these patients. So it's been fortunate, for me with that. Other times, yeah, if I'm in clinic with Paul, he'll certainly introduce me to the patient too and say, we've decided to do cataract surgery and Dr. Banas will be seeing you post-operatively, much like you and John are doing. So I do think that's a key strategy there too, to just kind of get the patient, more comfortable with you and your team as opposed to just one doctor and then, hey, we'll see you later and we'll go from there kind of approach.
Yeah, Nick, sorry to chime in, but
Mhm.
it's funny. As you were just talking about, that's the idea of a team approach, and then we have to, have patients understand that it's not just the surgeon or not just the optometrist; it's a collaborative effort. I just had heart surgery back in November. I had a bypass, and what was really fascinating was all my work, all the post-op healing of every sort, was done not by the surgeon. PAs and NPs were doing so much of the work, and even pre-op and handling post-op questions and changing dressings and writing prescriptions for pain meds or this or that. It wasn't the surgeon. And if you look at so many other subspecialties and so many other specialties of medicine in general, it's not just the surgeon doing everything. It's a team effort. And so it's whether it's NPs or PAs or other ancillary staff or other team members. Same thing in ophthalmology and optometry. I think we're seeing that. Look, the way we want to go forward now is just like every other specialty. They was kind of slow to catch up to that. But for us, and it's not just LALs. I mean, we do so much collaborative work with our optometric colleagues. I mean, as a glaucoma specialist, I don't see my post-op Zens and tubes anymore. I trust Jeff and the other team members, to do that. So I think it's just our philosophy has been a collaborative atmosphere. So this kind of just works so well in that kind of mindset that we already had.
So we introduced the idea of a team effort right from the very beginning, and we talk about it as like this is collaborative. So this process involves measurements, which are taken by our technicians who get the information on the shape of your cornea, the length of your eye. We'll be able to look at that and interpret, what is the best opportunity. The team also involves me as a surgeon. So I'll be the center of the team, and Nick is the power forward who then joins the team and achieves the best post-operative
I'm more of
result.
a shooting guard, but no big
Yeah,
deal.
yeah. Yeah, okay, maybe I'll have to change my
No,
pattern.
no, you're big. You're big. You're like 7 feet tall. You can protect that rim.
Yeah, but the concept is that the patients are introduced to this from the beginning. And quite honestly, Paul, it's exactly as you described in all the other professions, all the other specialties. Orthopedics is the very same thing. They'll do the surgery, but the actual recovery and the outcome is directed in no small part by the team that surrounds the operative outcome. And to the extent that the LAL is not only a reflection of that, it's a great example how in eye care, how in eye surgery, we can achieve better results because we have this solid team of experts.
Yeah, and
Yeah,
not to sorry to cut you off there,
right.
not to be cliche, but it really takes an entire village for this. It's not just Paul and I. It's the surgery team kind of supporting us from whether it's the consult and the scheduling and getting the medications set up for the patient there. Then our technicians post-operatively helping us room these patients, do the tests that we're looking for. My scribe really just helping me day to day to get the LAL process as efficient, managing those patients, getting them set up behind the instrument for me, and then me performing the procedure, the coordination with Dr. Singh in terms of, what I'm planning to do with the patient, how do you feel, and so on and so forth. And even all the way down to the front desk staff in terms of managing and scheduling those patients' appointment routinely and efficiently. It really is a whole group effort. It's not just the MD and the OD, even though we're focusing on that. I do think it really establishes a great example for how the entire practice is involved in a patient's care from start to finish, especially on a long journey, not just coming in for a quick exam, but how the entire practice can be involved in making sure that that patient has a great experience and a great outcome, at the end of the day there.
Yeah, you nailed it. I mean, it's not just us here on this call that are the team. It's the staff. It's the patient has their representation too. They've got their family usually that are part of this. And John, like you mentioned before, a lot of this is word of mouth now. So now we've kind of got to the point where it's always the husband that's the first to go under the knife, and then it's always the wife that follows. So the husband's always the guinea pig, which I always find is hilarious.
Yeah.
But they've got their representation too. They've got people with them that are kind of guiding them through, and I always encourage that too because there's a lot of stuff, especially when we're introducing this as a concept. It's like trying to drink out of a fire hose. There's just so much stuff getting thrown at you. And it's always nice to have a second set of ears. And then that patient comes from another clinic often. We always have our network of ODs who we trust that they probably know the patient better than we do. And so I take feedback from them. This patient really is going to want this. And I use that to kind of paint the picture and guide the art process of adjusting the lenses. I want to take an opportunity, too, to remind everybody that we do want questions. We want this to be interactive. So go ahead and type a question into the chat. We'll definitely get to it. I do have a question. I have two questions, a two-part question. Paul, this is for you. So number one, completely off topic, but I'm curious about the answer to this. Did you have a song that was titled Getting Miggy with It? About
Oh my
Migs
God. Yeah. So what that is so funny. Yeah. So what I learned many years ago was I was from Luca there. What I learned many years ago was how to divert the audience attention to something more fun that would put attention on what you have to say. So when I'll be nervous, I was like, let me just show a cool music video, and then they won't care what I say afterwards. That was the idea. So yeah, one of the things, we were doing a thing with Jason Backrack was I think on the panel as well. So I had Jason send me a couple of videos. I did like a whole like getting Miggy with it, like parody, and I shared at a couple of meetings. And after that, it was actually it was like a little help with my friends. I would do like all these parody videos and music videos over time. And so now it's like when I go to a meeting, after a while, I was like, am I only invited because I do a music video? Because it was like, where's your music video, Paul? That's why we invited you to this talk. I'm like, oh yeah.
I know. I'm hoping
yeah, that was one of the first ones I did. That was fun. That was a good.
You should be dropping some beats for us right now.
I know, man. I got to make one for you next time, next PT.
So on topic. Second part of the question: how do you deal with PCO during the 90-day global period? How does that work? I mean, because it's a silicone lens, you're probably going to see PCO a little bit earlier. And these patients who are now at macular potential, they're 20/15, there's only one way to go, and that's down. How do you deal with that? And then, Jeff, I mean, if you're seeing that, how do you coordinate that with Paul to do a laser? In Wisconsin, we have kind of a gray area with lasers, but you and I don't do lasers. So we have our surgeon counterparts do that. How do you guys deal with that?
Yeah. We've kind of gone back and forth with, do we wait until it's after the 90-day global period, and do we wait until they really are significant, if we can't refract into 2020 or 2015 or whatever it might be before we do the adjustments. And then we'd realize there's just too much, back and forth and not sure. So correct me if I'm wrong, Jeff, but I think we finally decided to go ahead and just do it automatically at like about a month out or so, 3-4 weeks before we do our first adjustments. Just do it. And we waive the fee. We just waive that. It's part of our kind of LAL fee. So the LAL fee is much higher than our range of vision packages and our astigmatism packages in our practice, at least. And so all that's kind of the package price, quote unquote. It includes, all the other things like the YAG capsulotomies that may not be covered by insurance. So we just don't even bill insurance, and we do it about a month out or so. Jeff, is that kind of what you've been doing for the most part?
Yeah. For, the beginning, I think we were kind of testing the waters and seeing what made the most sense, but then ultimately just, not only for outcomes, but for patient convenience. We didn't want them to have to come in and then we see them and go, actually, I'm not going to do an adjustment today. I'm seeing a little bit of this, PCO developing. Let me get you back to Dr. Singh, and then going from there and then doing it. It kind of just made a little bump in the road with that. So we all kind of discussed that and decided that it would be a pretty good idea just to kind of clean it off right in the beginning, kind of 3-4 weeks out is where we're typically doing that. And then after that is when I'm seeing him back and I'm starting the adjustment process. So we just kind of, prophylactically take care of it.
Yeah, I mean, there's different opinions, I think, on that. We don't automatically do it, but that doesn't mean that that's wrong. I think we do it usually when I can't get a good refraction. If they're refracting to 2020 and it's a really good endpoint, 2020 or better, then we don't really bother with the YAG. But there are on occasion where we do need to do it, and it's a no charge. I mean, if it's within the global period, we just kind of roll that into our price, and that's just a part of the process. But I usually tell patients early on that this might happen. And I always want to make sure that they're aware that this is always a possibility. Because if you expect it, then it's not a complication. But if you don't expect it, then it's a complication. Something went wrong, right? So I always do kind of set that like, hey, we may have to pause. And I set that up in the very beginning when we start talking about the process, that when we schedule these adjustments, and we schedule them once per week and we start them at 3 weeks. But just because we schedule an adjustment doesn't mean that we're doing it. It's tentative because there's always a chance that, I always use a golf analogy. If we're taking a putt, the ball could be still moving around. We want to take an extra week to read our putt before we actually pull the trigger because we only got 3 shots to do it. So if we do have a situation where I can't get them to 2020, well, we may need to delay. And usually we have really easy capability to get the laser done right away. Then we just, no harm, no foul. We just bring them back next week. We're not really delaying things that much. But there's different opinions, I think, on that. Jeff, why don't you walk me through? I want to hear how you guys do it in your clinic. Let's take it step by step. When somebody comes in for an adjustment, what's the process like working that patient through the clinic?
So, that patient will come in, they'll get called back by one of our technicians, and then that technician will do the initial workup, usually includes an auto refraction, maybe an aura, so that we can get a general idea for pressure. I don't like to touch the surface any more than I need to on these days, especially to just kind of optimize that refraction and then get the best data for the adjustment if I'm going to do one. This is, again, typically happening around week 3, week 4, once Dr. Singh or his partner, Dr. Singh, have done the first YAG capsulotomy on the patient. And then they'll bring them back in and, I'll review the data, make sure everything is making sense. But my technicians are technically checking the eyes monocularly in a well-lit environment. I'm seeing what their auto refraction is looking like. I will do the refraction myself. There's typically, and that's done also in a brightly lit room. I will be looking at the patient anterior segment at least heavily, unless something doesn't make sense. And then I'll obviously divert the process and go looking in the back of the eye, do a dilated exam if I absolutely need to. But we're typically just focusing on refraction and anterior segment. I'll take a look at the ocular surface heavily, making sure that my numbers aren't influenced by things like dry eye there. And if everything's making sense, then I will, decide what my targets are for those patients. Typically in the beginning, I kind of have just a standard philosophy where I'll use their dominant eye for their distance. And we've determined that, already with preoperative testing before the cataract surgery was actually done. And then I'll use the non-dominant eye for the near vision eye. I'm usually targeting plano on the distance eye and then -75 on the near eye. I give the patient, a whole heads up. Here's what the light adjustable lens is, just kind of a refresher. Here's what our goals are. Here's what I'm trying to do with your range of vision. Here's my expectations for after the first adjustment. You'll probably tell me your distance vision is good. You'll likely tell me your near vision is improved, and hopefully it's great too. Many of my patients right after adjustment number 1 is very happy and they have an excellent range of vision. But some of them might need a little bit more optimization after that, and that's what I tell them. I go, you might tell me, alternatively that this is going to be, it's good, but it's not quite where I want it to be, and then we'll have to play with that. And we'll have a little discussion about just, how optics works and how I can't break the laws of physics. And, there are things that we set expectations at that first one, and that first adjustment, post-op for me is the one where I spend the most of my time, just kind of making sure everything's in order, making sure everything's aligned properly, from an examination standpoint, and then just setting those expectations with that patient so that they know exactly what I'm planning on doing. Now, RxSight just provided us these new, wonderfully printed pamphlets that we can hand out to our patients. So that is now being incorporated. That's got a lot of data on just what to expect through the entire post-operative process. So now I'm telling them, like, here's this, if anything I'm telling you is going in out in one ear and out the other, you can go back and read this, especially after I've done your first adjustment and you've got a little bit better reading vision there. You'll be able to read through this and get a better expectation of what's going to come, over the coming weeks. And then we'll go from there. We'll usually do the first adjustment. We'll dilate that patient with tropicamide, phenylephrine, cyclopentolate, and then we'll, get them behind the instrument once they're fully ready to go. And then I'll do the adjustment on that patient with the, the prism and all that. And then we'll see them back the following week and see what kind of feedback they have, how happy they are, and then we'll play with it from there.
The pamphlets that you're talking about, those just came out. We just started using those in our clinic too. They're fantastic. It does, for lack of a better term, it dumbs it down. It makes it simple, what the patient should expect. We hand them out we're starting to hand them out at our week 1. We do a week 1 visit always. And it's mainly that visit, whether it's medically necessary or not, I use it for a data point because I do get a quick autorefract, or we use an aberrometer. Just an idea of where the refractive status is, and I use it as an opportunity to educate so they know what to expect. That just keeps things so efficient when they come in for their first treatment. But the pamphlet talks about what to expect. It even has like a little notebook in the back for them to write down concerns or questions that they might have. It keeps them feeling more involved. So I think that's a really great thing. The first adjustment, what I like to do for my patients, I give them 3 pieces of homework because 90% of our patients, if not more, are doing some blend. How many of your patients do a blend? Almost all of them?
Yeah, I would say, what I have found with this is that, most people come into this expecting that they're going to have a large range of vision after all this is said and done, and they're going to be able to dramatically reduce their dependence on glasses. I think Dr. Singh and Dr. Sanka, do a good job kind of teeing up the patients for me in terms of expectations initially. But I've also found that, if there's especially a patient that really wants to push that near vision, they think they want that near vision as much as they say they do, and then they see the little bit of compromise that might happen at distance, and they go, actually, I didn't want this as much as I thought I did. Cut me back a little bit, and I actually do really prefer the distance. So there are patients that do only distance only, and with the extended depth of focus of those lenses, especially the LEL Plus now, they are getting really good near vision, and they are very happy, right off the bat, and may not want much adjustment for the near or any at all. I have had a couple patients that have said, no, I'm actually really good right out of surgery. But typically, yes, I would say most patients, we'll say 90%, anecdotally here, would like that blended, range of vision where they can function at all ranges pretty well.
Yeah, so assuming that's the case, like you said, 90%, that's about where we're at too. Some do want that distance, and that's totally fine. And even especially with the LAL Plus, if we set them for plano on both eyes, they're usually functional, at least at computer distance, pretty comfortably. But if we do a little bit of a blend, now the degree of blend is the variable in everybody. I tell them 3 things. Number 1, use your tears all the time. Because the light adjustments are going to dry your cornea out. It's a lot of intense UV light, and your eyes are going to feel scratchy, just like if you spend an entire day at the beach. You're going to leave feeling crispy no matter how much sunscreen you put on. So use your tears. Number 2, never compare the 2 eyes, right? You've got 2 eyes now that are intentionally different, and we want your brain to we want to trick your brain a little bit. Just like I have 2 hands. I'm a baseball player. My left hand is garbage for most things, but I don't notice that unless you tell me to throw a baseball with my left hand. Right now, sitting here, I can't tell that my hands are different. So when you isolate the 2 eyes, you're going to notice it. So try not to do that. And then number 3, and I think probably most importantly, if we're trying to give you reading ability, don't reach for those reading glasses right away, because that's what they always want to do. Reading glasses magnify things. They make things easier. They are called cheaters for a reason. You're cheating the system. Don't cheat. Try to avoid the reading glasses as much as you can. I think that's just such a very basic thing. And patients come back and they're like, I did it, Dr. Bruns, I did it. I didn't use my reading glasses like you told me to. Awesome, cool. And they're like, well, it wasn't good enough. Okay, cool. So let's make it better. And that's where the feedback comes in, and that's where the process. That second visit when they come back on LDD number 2 is my favorite, because now you got them. They've seen the magic. They know how it works. And they're kind of involved more than they used to be. They were skeptical before that, but once that change happens, it's just so cool. So you said lights on for the refraction, right? That's pretty important, I think, right?
Yeah.
Explain why.
That's going to give you better contrast sensitivity ultimately there, and that's going to give you a better, more accurate refraction, I would say. Sometimes, sure, we like to do refractions in lowly lit environments so that we can really see, how the pupil dilates and how we can optimize the refraction. But most people, don't spend a lot of time in poorly lit environments. And when we're dealing with, premium products here and premium implants and premium expectations, we're going to want to simulate the real world as much as possible, and that's going to be in a well lit environment. So yeah, I typically do everything in brightly lit rooms there.
Mhm. So, in the spirit of collaboration, we have another question that came through. So, can the LAL be done in conjunction with patients receiving retinal injections? John, why don't you take that?
So we actually get referrals from retina doctors. The common wisdom has been you can't really do a multifocal patient in someone who has AMD, dry or wet AMD. Just that the noise, the visual noise that's introduced from the multifocal lens tends to be synergistic in terms of the interference you get from a macula that doesn't have full potential. The exact opposite is true with the LAL. It is a single vision lens at the end of the day, but it has that unique EDOF quality. But what it doesn't do is it doesn't introduce aberrations into the visual system that interfere with whatever macular potential is there. And so sometimes it's difficult to know what a patient will want for their post-op refraction who has maybe some dry AMD or who has treated and stable but wet AMD, and they may want to be a little more nearsighted, or they may find that what optimizes their quality of vision isn't easily predicted by the conventional decisions that we make with someone who has a normal macula. So we actually preferentially will choose the LAL for patients who have macular conditions. And the same is actually true for patients who have Guttata. Not every Fuchs patient has to have a corneal transplant. We know that. But we also know that patients who have Fuchs can have, visual aberrations that are exacerbated with a multifocal lens. And you have to be very careful about how you choose your patients for a multifocal. And simply, it is just not the case at all with the LAL. So we're doing the patients a favor by giving them the LAL. So, Paul, I'd love to hear your read on this, because that's really the decision we've kind of come to with experience. But I'd love to hear what you think about it.
No, I'm glad you brought that up, John. And you just made a great comment about really giving these patients the best option, the best quality of vision you can give them. You're doing them a favor. And what I think it's the same thing for not just retina, and I agree with you on the retina side, but also glaucoma. When you think about one of the earliest changes that we see in glaucoma patients, it's loss of contrast. That's the earliest finding actually in glaucoma before we even lose field loss. Number two is that when you think about unhappy quality of vision patients from a multifocal lens, it's not the refraction. It's not that they can't see the Snellen chart. It has to do with contrast loss. And a lot of these multifocal lenses, although I use them a lot and I still think they're great, but they do lose anywhere from 10, 15, 20%, depending what type of lens you're using. That can be enough even for a non-glaucoma patient to not be happy. Then you add someone who has pathology of retina or glaucoma, et cetera. And so I think that's what makes the LAL such a unique kind of tool, is that it does not exacerbate or negatively affect any other comorbidity you might have, like cataract, like glaucoma rather, or retina. Number two is I think when you have these conditions like retina pathology or glaucoma, the key is to help maximize the quality of the image hitting the retina. If you don't have a lot of cells left, whether it's glaucoma or retina, make those cells work the best they can and get that image quality the best it can be. So for me, when I tell patients with the LAL, and even if they, let's say, have some pathology in the retina or some, let's say, glaucoma field loss, I'm like, look, I'm not going to reverse your field loss. I can't reverse your retina disease, but I can, whatever cells are functioning, I'm going to give them the best quality of image they can possibly have. And that's what the LAL does by giving them that perfect option and really kind of nailing that refractive targeting. And so I think, long story short, John, I agree with you. I think this is a great option, especially in those comorbidities that we see a lot of.
How about with MIGS? Do you do MIGS
Yeah.
often? With,
Oh,
yeah.
yeah. I have some great videos online if you guys want to see it on iTunes and YouTube and all that stuff. Yeah, with canaloplasty, stenting, even goniotomies. I think for me, In general, the goal for me has always been try to get people off of glaucoma drops, and that's just because ocular surface disease. I mean, we know compliance, we know all the studies on that, but when you have people on any even a one PGA, you can see significant loss of goblet cells and meibomian gland dysfunction and tear film instability, and that, as you know, what you just mentioned earlier, that when that surface and Jeff will always tell me, nope, sorry, we can't, we got to hold off on that adjustment right now because the surface is still dry, and a lot of it's because of glaucoma drops. So I think yes, I'm a huge fan of getting rid of those drops. And MIGS is one of the greatest tools that we have now at the time of cataract surgery to really help get them off of drops. And you may not get them off of all, but if you can even reduce one drop, you can really significantly positively affect their compliance, but also the surface as well. And I think it's a great combination. Absolutely. And I think it's a safe lens in those patients.
So, Paul, I think
Jeff,
we've all learned a lot from you, Paul, with that. And we're routinely doing MIGs on patients who need the extra oomph in their pressure control, but definitely with the LAL, there is no contraindication. Quite frankly, I think there is an indication because it fluffs up the anterior surface, which makes the quality of vision better. It's true of all patients, but in glaucoma especially.
from the LDD standpoint, then Jeff, with a MIGS especially, is there any delay that you're going to do? I mean, is there going to be any influence on the refractive accuracy in these patients? Like
Yeah.
say a canaloplasty, where it might be a little bit more of a, maybe a more prone to a hyphema or something like that.
Yeah, so we're going to focus on the main postoperative care. One of the nice things about the LAL, and we've talked about this in depth, is the ability to test drive and that there's no rush to do the adjustments for these patients. So when we have some of those comorbidities that we're doing combined procedures, with the LAL and the MIGS procedures, for instance, it's going to depend, number one, on what that mixed procedure is. And like you mentioned, sure, if there's a canaloplasty going on and perhaps there's a hyphema there, then we have to wait for that to clear out and make sure it's not affecting the implant itself before we do anything, which I haven't really seen any complications with that. Pressure, if it's not controlled for any reason, if it's super high, obviously that can have an impact on our refractions too. So we want to get that under control. And then, I do want to try to minimize as many drops as possible. If these patients are on drops, I do want to see stabilization of those pressures before I start pulling those drops away and then helping to optimize the surface. So these patients, they still do well at the end of the day, but the process might be a little bit longer. I'm going to probably focus on the MIG stuff first and make sure that gets all under control. And then I'm going to monitor my refractions throughout that. And those refractions might go on for, months instead of weeks until we actually see the stability that I'm looking for, depending on how many drops the patient's on, how much we've reduced that. Some of these patients can have more inflammation than your standard cataract surgery right after surgery. So we're going to be upping those steroids. They can be on the steroids for a longer period of time. That can unfortunately beat up the ocular surface. And then we might have to, play around with that. So the only thing I would say is with those mixed procedures, it just might present a delay into the overall timeline of things. But when it's all said and done, like, Dr. Singh and Dr. Vukich were talking about, I think it still gives them the best chance to have the optimal vision, outcomes given everything. And by the way, we're lowering your pressure and we're getting you off of these drops and we're just trying to improve your quality of life, overall. So I think it's a great tag team duo for those two, but we have to set expectations in the timeline with that for sure.
It's truly two birds, one stone. I mean, I think the decision, this isn't a MIGS talk, but I mean, I think it definitely lines up with glaucoma, very, very parallel. If we have an opportunity to do something and we're already going to do cataract surgery, why don't we at least consider doing something that's premium refractive and getting you out of your glasses? That's a lifestyle choice. But then it's a no-brainer to do something to get out of get away from the drops if we can. We're going to preserve your ocular surface. We're going to reduce your financial burden, your need to do the drops. Drops are hard to remember, right? So we can do something to do that. Now, Jeff, you're totally right. I think it does delay the process a little bit, and that's just an expectation that has to be set. Now, we're doing two separate surgeries, essentially, on the same day at the same time. And so let's just combine the post-op, but we have to delay it a little bit. And so you as the patient, you're expecting a certain outcome. I want to get you that outcome. And we can do this faster if you want. I always tell them too, we can do this faster. There's nothing wrong if we do it the old-fashioned way. It just means that you probably wear glasses and you may still have to be on the eye drops. But let's take advantage of this opportunity while we have it, because this is not a decision that we're going to make again. This is a once-in-a-lifetime thing. We don't ever plan to do it again. So let's make the right choice. Now, what's the long end for you? I mean, what's the longest you've gone before you've locked a patient in? That's the question I get all the time. How long could you go? Do you have any
Yeah,
thoughts on that?
those Paul, I mean, we've got a patient we probably comes to immediate mind. This is probably 5, 6 months before, we were finished. Lately, I don't know if it's just something in the water or something that I'm maybe paying attention to a little bit more in terms of how it can impact. But we've had patients complaining about floaters a lot too now, and kind of, impacting their quality of vision, at least in the dominant eye. So a lot of times I'll delay and we'll do treatments on those floaters just to go from there. But RK patients are really the ones that come to mind when I want to think about how long it can take, because it can take a long time for that cornea to stabilize after the initial procedure. So we might not see stable refractions for 3 to 4 months after surgery. And then once we get those stable refractions, we're talking, maybe another month before the adjustments are completed. We can be out into that 4 to 6 month period before patients are happy. The good news is we don't have a time limit on this. We can, get to these whenever it's appropriate. I've had patients go on vacation for the summer, disappear for 3 months, and we did surgery in the beginning of the year and they're gone for the summer. They're back in the fall. And, it might have taken 8 months, not because of anything from a surgical standpoint, but, or the process, just because they had life get in the way too. So, there's not a specific timeline, but yeah, it can go a while there if a patient needs to, or if the medical history dictates it.
I think 6 months is kind of like, John, what do you think? I mean, 6 months is kind of what I think, but
That would be as long as I would intentionally have someone wait. Although we've had a situation where we had one patient who had LAL, had one adjustment, loved it, didn't think they needed to come back, spent the entire winter in Florida not wearing any protection. They did deep sea fishing with glasses without any protection, came back for like, okay, I don't know what we're going to see. It came back and he was still 20/20 plus in both eyes. And we said, look, we got to lock you in here. But so I know that that is off label. We would never suggest that. But I think you've got enough time that you really don't have to feel that you're in a hurry to do this. And I know that there are practices, internationally and in Mexico, there are a couple of very prominent surgeons who don't have their patients wear glasses at all and delay the lock-ins quite a bit. So we have some latitude in that. And of course, that's off-label, and our Excite would never advocate for that. But the reality is we have time. It's really kind of by the patient's desire to get it finished. And quite honestly, one of the criticisms I've heard from doctors who don't do the LAL is, oh, it takes so long and there's just so much additional effort and it's inconvenient for the patient. Quite frankly, we get almost no feedback, negative feedback from the patients. I think by and large, they understand this is a collaborative effort and they enjoy being part of this. And they understand there's really nothing or almost nothing more important to them than their vision. And we're doing everything to give them the best possible vision for every waking moment of the rest of their waking days. Work with us. We're on the same team and you're going to love the outcome. And patients really accept that. So a long answer to a good question is, how long can you wait? Quite frankly, as long as you want, I think is the answer. And the RK patients are a great example of why delaying is a good idea.
And nobody really pushes back on the time. I think when we started doing this back in 2020, we had it set up in a way where we were doing 2 adjustments per week. It was Monday, Thursday, Monday, Thursday, Monday, Thursday. And more often than not, I'd do our first adjustment Monday. They'd come back on Thursday and they'd be like, I'm going up to the cottage this week, or I'm going fishing, or I'm going golfing. I can't make a decision on what I want to do yet because I just haven't lived enough with this I haven't test driven it enough. So we push out, and we found that that second adjustment was more often than not just getting canceled. We weren't really doing anything. So we pushed them out a week. And then for some patients, it's more. But that one patient you're talking about, John, I remember that. I was doing house, just kind of spring cleaning, and I was going through my folder of open treatments and like, holy crap, where'd Sandy go? Is she okay? Let's make sure she's still alive and still with us. Called her and she's like, yeah, I'm in Florida. I love my new vision. Get back up here. Oh my God. But she was fine. She was super, super happy. 2020, we locked her in. She was cool.
So like the active shield, that makes that's so nice though, having that active shield. I'm not sure, when I first started utilizing, the LAL, historically they didn't, because before they did the active shield, and I heard some stories of people's, visions changing because they didn't wear the glasses, but we don't see that, we don't see that now with the active shield. It's something that I'm curious to see if you guys, do you emphasize the glasses outside or inside, or how do you work with, how do you educate patients on that? I'm just curious.
But we tell them, only outside, only during the daytime. You do not need to wear them in the house or at night. You don't need to wear them, even if you have like windows in your house or we have windows in our office and we're worried. I said, don't worry about it. If you're inside, you're fine. And we've been doing this now for what, 2 years, Nick? I mean, we really
Yeah.
don't ask them to wear glasses except outside, except during the daytime. I'm not even sure that's necessary, to be honest with you. But we do ask that, and I guess we'll stay with that until we, feel comfortable otherwise.
It's kind of what we do. Very similar.
Just outdoors. Do you tell them to differentiate between the tinted and the clear pair? Does it matter?
I don't say much. Go ahead, Jeff. I'll let you.
Yeah, no, I don't tell them to differentiate between the two. I tell them, really ultimately whatever you're comfortable with, your light sensitivity level. Obviously, if it's really bright outside, go ahead and put the dark ones on. But I tell them just outside at all times. I don't tell them not at night because sometimes I'm concerned just about UV exposure through the cloud deck. So I'll tell them, still wear the clear ones maybe at night when they're outdoors, and those will be situations where I'll differentiate between the two. But I'm the same way. I tell them you don't need to wear them inside. You don't need to, worry about the windows, things like that.
What about a car? Anything?
Well, I mean, most cars north of 2005 have UV coating protection on the windshields already, and the surrounding windows. So I asked them, how old's your car? And if it's older than 2005, I tell them you're fine. If not, then wear the glasses anyway. And one of the things that I tell to my patients frequently, regardless of especially if they're concerned about the time that it's taking with a lot of these things, we're waiting for stability, or just emphasizing the need to wear these glasses. I go, look, you invested a lot of money into this process, so we're making sure that we're doing everything we can to get you the outcomes that you want. And this is one of the ways we do that. One, we wait for stability with things like refraction. And two, I need you to wear those glasses at all times when you're at least outdoors there.
Yeah. What I used to tell people was mostly, especially indoors, if you're in a room that you could keep a plant alive, then I'd wear the glasses. But I've even kind of gotten away from that lately. I mean, from just talking to people and talking to colleagues. I mean, if you can keep a plant alive, that means there's UV exposure, right? The question is how much and specifically what wavelength. So, but I've kind of gotten away from telling patients that too, just based on conversations like this. That's probably overkill.
Jeff, you brought up a good point about the more new cars. If it's less than 20 years old, actually beyond that, you can get antique plates in Wisconsin. But, the reality is it's not like the car manufacturers were actually worried about, macular potential or cataracts. They did this so it doesn't fade the interior. And so they want to make sure that their, car upholstery and vinyl doesn't crack prematurely and whatnot. So yeah, all the car windows are UV protected. And so it's probably more than sufficient, even if someone's taking a long car ride. I just tell them not to worry about it.
Yeah. So I got a question for Paul and John, and for people who are maybe new to the journey and new to getting on board with the LAL. And obviously you guys struck gold. You got two awesome ODs that work for you clearly. So how do you find...
You say so yourself. Yeah.
Oh, you're right. It is me. Should I didn't listen that. Wow. So how do you find an OD to do this, if that's something you're looking for? Or another question that just came in, kind of related, there's open access centers that are becoming more popular across the country. How do you find the right team to work with? How does that work? Any advice at all?
Well, I think it's... I'll back up. I think, specifically finding an OD specifically for light adjustable lens is different than I think just how do you find a good OD who you want to work with and who want to join your practice or really collaborate with. I think you really got to have a good communication pathway. Number one, you have to also have a really good rapport. I mean, you really got to trust each other. You got to involve each other. You got to trust. And I think that's probably the biggest thing that I've noticed, with Jeff is really when he came into this practice, he was very medically oriented. And one of the things we love about Jeff is he just wanted to learn. I mean, it was the best part of it for me was like, God, this guy is like, I felt like it was like I always wanted a fellowship, right? And I was like, this guy's like a fellow Macmini, not anymore. He's like he teaches me stuff half the time. But it was just great to see this kind of mind that just says, I want to be a sponge. I want to understand. I want to learn. And that collaborative atmosphere is just because we both wanted to learn from each other. And it really, truly was that. So for me, I think those are the key factors. You want someone who just wants to learn, wants to grow, wants to never be complacent. My dad told me that many years ago. One of the phrases I always used from my father, who was an ophthalmologist, and he passed away back in 2019, was, Paul, never be complacent. always, think about it, what can we do better? And that mentality, I think, is something that you really want to have with any person who's joining a practice or you're working with, especially in the context of something like LAL. So I think that's the bottom line. You can teach, it's not that hard. I think we think that we have to have someone who's super smart and super intelligent and on board scores and this and that. To me, it's all about personality, and it's about your quest and your drive to do better, for your patients, for your practice, for yourself, and to learn. That's, for me, has been the bottom line. And of course, Jeff exemplifies all that, and we've been lucky, no doubt.
Thank you, Paul.
Yeah, I don't even know that I can add much to that, Paul. It's exactly right. You're looking for someone who wants to learn, someone who wants to continue to be part of cutting edge technology, and someone who is comfortable from a procedural standpoint. Because at the end of the day, the light adjustments are, you can think of it as a procedure because it is, and who wants to be involved in patient care at a level that is meaningful. And so some of it is quite frankly just on the interview. If you're looking for someone to join as an associate, it's like, well, what do you want to do? What are you looking for? What are the things that you find personally fulfilling? And how do you want to be a part of this team? How do you see yourself interacting? And I think the self-selection occurs where there are individuals who, so clearly want that as part of their journey in their profession. And they don't want to leave just a trail of individuals wearing contact lenses or glasses. They would like to treat individuals who have conditions that are treatable, who can optimize quality of life, who can be a part of their life journey in terms of a way that makes things better. It's so fulfilling but again, those are individuals who kind of self-select. So where do you find them? I think it's really just a matter of they kind of find you, in all honesty.
Yeah.
Word of mouth helps.
Yeah, it
Hey,
does.
Nick, you got any good optometrists anywhere?
Yeah, this is like part of this collective, this hive mind here. I don't think you can just stick anybody into this role and expect it to work well. I don't. And I've talked to clinics who are, struggling with the technology, and most of the time it's because they've got somebody doing the adjustments who just doesn't have a passion for it. It's not hard, but you do have to have an elevated level of understanding of optics and the visual system. Higher order aberrations is a big part of this. And you do have to have an understanding of that. But really, when you boil it down, it's not that hard. The procedure itself is really easy. You're just pushing a button and holding the lens. It's just like saying that painting a picture is not hard. My 4-year-old can paint a picture. But painting a picture, there's different levels of aptitude with what painting a picture is, and painting a good picture versus painting a picture that looks like it was drawn by my very talented 4-year-old. Two different things. So you have to have an understanding, and you have to have a motivation, because the other half of this whole process, I think, Jeff, from your and I, our point of view specifically, it's psychology. Some of these patients, they come in and they do have a sense of entitlement because they paid top dollar for this, and you want to make sure they get the outcome that they deserve and that they paid for. But there is a psychological aspect to this where it's like if you give a mouse a cookie. I think I say that all the time. If you give a mouse a cookie, they're going to ask for a glass of milk. Then they're going to ask for a bedtime story. And then how much is too much? The definition of perfect is highly subjective. Everybody's definition of perfect is better. But patients come in, I want perfect vision. Well, what does that mean? Perfect is 20/20. But to the patient who paid $10,000, 20/20 maybe isn't good enough. So I think the psychology of this is really what separates the good from the great, and the ability to have that personality and that personal connection to the patient, and then also building the rapport with the team, the surgeon, the staff. I think that's all a part of it.
Well, I think that's, you hit it on the head in the sense that sure, there's a technical aspect to this in terms of the procedural, but yeah, I mean, we all were trained on optics. We all can use a gonio prism. We all can, figure out how to get a good refraction there. That's not hard. What I think a lot of us miss, we think of ourselves as doctors, but yeah, and we are, but we're in the business of people here. We're in the business of building relationships. We're in the business of, trust and earning that trust and selling that trust. You're not selling a product half the time. I mean, it's not even just with the light adjustable lens. It's with a treatment plan that I've decided, that I think is valuable, and you got to get that patient's buy-in, because even if they feel like it's not the right treatment or they're not 100% confident with you, they're either not going to comply with that treatment or they're going to go somewhere else for a second opinion, right? So the biggest skill you can have is not what you learned out of school, but rather, your people skills and your sociability and your ability to, talk to people and comfort people. And if you're spending a lot of time with those patients, that's a good thing in that sense because you're building relationships there. And yeah, there will be times where I do spend a lot of times with patients simply because I'm getting to know them and because I'm dealing with some of, the psychology. What are your expectations and how do we get there? And what do you want to do? What do you like to do? All that kind of stuff is really a part of the job too. And if you're not interested in that, then the reality is you're not in the right business at the end of the day. You're going to hate what you do. So, in terms of for those MDs looking for ODs with this, I mean, you got to find an OD that wants to do this. You got to be motivated to this. You got to be able to willing to learn. I mean, Paul will tell you, Paul initiated, the conversation in the beginning where he was saying like he wanted to learn and he wanted to do it. And he had every right to do that. But I was a nagging person in his ear, like, when is my time? When is my time? When is my time? Like, I want to do this. I got my buddy Nick up there telling me all about how great and how awesome it is. Like, when can I, hang out with him and do that kind of stuff too? So that's just me. I mean, if there's any of my classmates on watching tonight or even my professors, they'll tell you there was nothing special about me academically, especially in school and definitely coming out of school. What made me strong and what built the relationship with Paul is ultimately my desire to master my craft. I don't really care what accolades I get. I don't really care, what comes my way financially. I don't care what people think about me ultimately, but I want to be able to tell myself, look in my mirror and go, I did the best that I could possibly do for the patients that I was seeing. It wasn't just seeing patients and collecting a paycheck. It was just mastering my craft. So, getting that opportunity to work with Paul, I didn't know anything about Paul. I didn't know how well renowned he was, in the industry and things like that. I didn't have any motivations. I just wanted to learn and I wanted somebody to teach me and, put my feet to the fire in situations that I was uncomfortable with. And that's what the light adjustable lens can do for you. It can take you into that next step in terms of you're not just doing refractions, you're not just doing, gonio lenses. You can kind of put all this together. You can do the procedure. You can then, get great outcomes for patients and you can feel extremely rewarded at the end of the day and be a part of that and be a part of a successful practice that does that for patients. So you don't have to be anything special. You just have to, love what you do ultimately and want to do it.
You raised so many good points, Jeff. I would maybe add just a little bit of additional color in as much as anyone who is really good at something makes it look easy. And they'll tell you it's not hard. Well, the reality is, once you're really good at it, it's not hard. So there is a learning curve, and there is certainly an amount of dedication, like you said, to I'm going to be the person who's the master of this. I am going to be really good at it. And so the reality is the techniques and the subtleties and the things that make you really good at it make it look easy. But the reality is that there's a little bit of a learning curve for sure, but there's a lot to master the skill set, and not that different from so many other procedures and things that we do. You can become very good at it and make it look easy. But at the end of the day, it is that dedication and that desire to be the best you can be. That's really what sets you guys apart.
Yeah. I think we have students that come through our clinic all the time, and they always, John, they spend a day with you in surgery and they always come back like, that seems kind of easy, to do cataract surgery. Well, it's not, but it looks easy. But the difference between a good surgeon and a great surgeon is what happens when things go not according to plan. How do you fix things on the fly? And I think there was a case you had, John, where something didn't go perfectly right. And you were super calm and just everything went fine and the patient ended up beautiful. But I know in your head, probably things were not, it was like a duck with the feet underwater, like things were going crazy. And Jeff, you and I deal with that too. I mean, from the LDD and post-op, sometimes things aren't exactly like they're supposed to be, but the calm, very reassuring attitude and that collaboration with the patient, making them understand that we're here as a team. Nothing is wrong. Let's not get worried about anything. And this is a process. Let's not get worked up over maybe the first adjustment didn't get what we wanted it to get. Let's reassess. Let's take a step back. Maybe we need to address the tear film. Maybe we need to, battle some rebound inflammation. There could be a number of things that we have to do. That calm, I think, personality, and that's really where the art comes in. It's the ability to handle the patient on the post-op to make sure that we get the outcome. Guys, I think that really wraps up everything. That was an awesome talk. I want to thank everybody, John, Jeff, Paul. Thank you guys so much for contributing tonight. That was a really great conversation. Thanks for everybody who jumped on board. This is recorded, so this will be available on the peer-to-peer.academy website. We'll have another webinar sometime next July. Keep an eye on your email inboxes. Awesome.
Thank you. That was awesome.
No,
Thanks, guys.
Appreciate the opportunity.
Thank you, guys.
Take care, everybody. Thanks.
Have a good evening.